I am Dr. Anton Bilchik, Nadia's older brother.
And I'm the younger sister, Nadia Bilchik.
We are inundated with misinformation as it relates to healthcare. And what we are trying to do with this podcast is to have a discussion based on facts, based on peer-reviewed publications, based on credible sources.
So join us so that you can live long, live strong, and live healthily. Well, a very good morning, good afternoon, good evening, wherever you are. I'm Nadia Bilchik, joined by my wonderful brother, cancer surgeon and researcher, Dr. Anton Bilchik. And today we are really delighted to be joined by urologist and urologic oncologist, Dr. Jen Linehan. So, and we're so excited to have Jen join us on our podcast. Tell us why.
Yeah, Jen is an exceptional individual. She's not only a talented urologic surgeon, urologic cancer surgeon, researcher, but also someone who I have the pleasure of working with on a daily basis. And there's so much going on in the field of robotic surgery, artificial intelligence, that relates to what she does every day, which is urologic surgery, and also what I do. And I thought this would just be a great topic to really focus on some of the precision elements of surgery today.
So, Jen, of course, when one thinks urologist, very often one has this vision somehow, and I've spoken to many people about this, about the stereotypical doctor treating the stereotypical more mature man with certain issues related to prostate and all the discomfort that comes with that. But we know it's so much more than that. So, first of all, thank you again for being with us. But your work is broad. Can you give us some understanding of what you do every day?
Sure. Thank you both so much, Nadia. I'm honored to be here. And Anton, it's great to get to talk with you. You know, Anton, we've been working together for almost 10 years. When I came, I was still kind of a little junior out of my fellowship, and Anton's been such an incredible mentor. And I will say, since I've come, Anton has also really joined sort of this robotics movement in surgery, as well as minimally invasive surgery. But where robotics and AI has played the biggest role out of any of the specialties is certainly in prostate cancer, kidney cancer, and bladder cancer, which are most of what I see. And obviously, there are so many men across the country that are affected by prostate cancer. And one of the reasons that robotics was so pivotal in this group is that when you were doing open surgery, you literally had to get under the pubic bone to see where you were, to see where the nerves were, to see where the prostate was. And when robotics came in, you had this magnified camera view that showed you where the prostate was, showed you where the nerves were. So dissecting under this bone all of a sudden became you became more incredibly skilled at this. You could see all the structures, and it really revolutionized prostate cancer. And so it improved men's outcomes after surgery, and that started to make a huge difference. And when I started my fellowship at City of Hope, in 2010, even by that time, 90% of the men were getting surgery, prostate cancer surgery, by robotics. But now the field has expanded in multiple different ways using technology that we're actually learning less and less about. We're actually learning more and more that we have to operate less and less on some of these men. So, but we still use it for kidney cancer and bladder cancer. And those are sort of really my passions and loves at St. John's.
And yes, a vast majority, as you say, is men and prostate, but there's so many other cancers that you are having to treat. So won't you talk about some of those that impact both men and women?
Yes. So for patients that are men and women, there's kidney cancer and bladder cancer. And typically, what I'm seeing as the first symptoms of those, or what we're working up, what we start to get worried about, starts with a very simple urinalysis. You go to the doctor, you do your wellness check, you give a urine sample, and they actually find red blood cells in the urine. And from there, we tend to work up doing CAT scans, or sometimes we need to look in your bladder. And both for kidney cancer and for bladder cancer, that may be the first thing you see, because sometimes they're silent. And I'll have patients say all the time, well, if I had a bladder tumor, wouldn't I know? Wouldn't I feel that? If I had a kidney tumor, wouldn't I know? No, you may not have back pain. You may not have pain in your bladder. So I think getting these basic screening tests, and urine is a very easy screening test to get, can really help patients understand where they are and make sure that they're not, at risk for these cancers.
A question that I often get is, are there specific, signs and symptoms of gastrointestinal cancers that you kind of know that you've got a colon cancer or a stomach cancer? And how, as it relates to kidney cancer, for example, you mentioned some blood in the urine, but how many times are you diagnosing kidney cancer in people that don't necessarily have blood in the urine, but land up perhaps getting an X-ray or a scan for stomach pain or some other reason?
Yeah, I mean, for kidney cancer specifically, most of the time we're diagnosing this is an incidental finding. They came to the ER, they had back pain, they got a scan, and then I'm getting a phone call the next day that they found a tumor. And the good news is usually in those settings, we're catching it very early, because if they're smaller tumors, you don't have to remove the whole kidney. You can just take out part of the kidney. And again, using robotics has made that much more facile, and the outcomes have been better because you're able to preserve sometimes 90 to 95% of a patient's kidney.
There have been major medical discoveries and advancements in the 21st century in genetics, pharmacology, surgical technique, and medical device technology that have opened up new pathways to innovation today. And now, artificial intelligence holds great promise in personalizing healthcare and treating patients with unique protocols designed specifically for them.
AI is clearly the future of robotics. The ability to really refine what we do, to improve patient care.
Robotics really changed the way we performed surgery, because for urology, we could be in spaces that we could never be in before, that were too small to be in.
In neuroscience and neurosurgery, we've seen an amazing evolution of imaging. We can see the brain at work, the function of the brain in images like MRI scans.
Right now there is an AI robot called Moxie that delivers specimens, pick up specimens. Artificial intelligence has allowed us to get back to more meaningful work and spend more time with our patients.
Join us as we explore the intersection of human ingenuity and technological prowess. From groundbreaking advances unraveling Alzheimer's, the boundless future of robotic surgery, the emergence of digital knee technology, and the transformative potential of cochlear implants. Get ready to experience the convergence of science fiction and reality, where every breakthrough propels us toward a healthier, more technologically empowered tomorrow.
Jane, take us through. You make an incision, you use the robot. How does it work? And I'm curious again how you and Anton work together on this.
So I think when the general population thinks of robotics, or you say that to somebody, they think this is an autonomous robot that's going inside and cutting on the patient, which is not really what's happening. We are sitting at like a console or sort of a visual screen where the surgeon can move the robot inside the body. So we make tiny incisions, put in very small robotic arms through ports through these incisions. And then we can control the arms, which are very similar movements to a human hand, inside the patient, but on a very small scale. And so then we're able to be in places and see things that maybe we would not be able to normally see if we had to make larger incisions. And it has been proven that using minimally invasive surgery with robots, patients recover faster because the incisions are smaller. There's actually less bleeding because you're taking up less space and moving less organs around to get to where you need to go. But it's revolutionized, a lot of our surgical procedures because of the technology that's coming through the robot. But it's not an automated process, and that's often a question that patients will say. So the robot's going to operate on me, or you are? No, we're still in control the entire time.
Which means there's a margin for error. So if you are somebody who is considering any kind of surgery like this, how do you know that you have a Dr. Linehan who is so skilled? Because it can easily go wrong.
Yeah, so I think for patients, they will often ask, well, how many cases you do? That's a good way of knowing for patients, how often the surgeon is performing this procedure. And then for me, especially, when I came out of my residency in urology, which for most surgeons is about 6 years, I went and did a fellowship for 2 years. And in those 2 years, every year, I did 350 cases of robotic surgery. So by the time I went out in my own practice, I had a lot of cases under my belt. So this wasn't something new I was learning.
And I have to say that the absolute game changer when I was training, because I'm a few years older than Dr. Linehan, who's very, very young, but at the same time enormously experienced. She's not that young, but
not that young. She is very experienced.
But she's very experienced. We were making huge incisions, whether it was to, or the urologist was take out the kidney or remove the bladder, and just the notion that that Jen can do these operations with total precision. And I've watched her operate. She truly is an exceptional surgeon. Through small incisions. And as you mentioned before, to be able to take out, for example, a kidney cancer, but still preserve part of the kidney, which is often a little bit of a joke between the two of us, because it's so much easier just to remove the whole kidney, just remove some blood vessels, the urine comes out. But she makes every effort to preserve part of the kidney that is normal. And people just go home in a couple of days. So that really, you talk about precision surgery, the outcomes are quite revolutionary.
So for people who are listening to us, watching us either live or recorded, and you are concerned about either you have a UTI or there's prostate cancer, what are some of the preventions? Because Jen, Anton and I have spent a lot of time talking about early screening. What's an anti-inflammatory diet? What is something you say to all of your patients about overall wellness when it comes to urological issues?
Well, again, I think I will go back to the very basics of what are your symptoms? Are you having burning in the urine? Are you having back pain? That could be a kidney stone. Are you seeing blood in the urine? I mean, clearly that is something you want to call your doctor about right away. But I think there's some simple urologic metrics you can go by if you're a patient to kind of figure out, am I at risk for something? For prostate cancer, there's a PSA blood test. For bladder cancer, we have several urine tests on the market now that can help with screening for bladder cancer, and they're readily, available. So I think doing the basic screening tests, just your blood work, your urine tests. If you're having back pain, you can get something that is simple as an ultrasound. I mean, even ultrasound technology has gotten better over the years that we're able to see more, and most urologists can even do that in their office. So I think that there's some basic non-invasive tests that patients can look forward to every year that are going to be good screening metrics for them. And, one of the things that we're working on at St. John's, and we have some amazing researchers in transcriptional research, which is where we look at the microRNAs and the DNA and the mutations, are Dr. Hoon and Matthias Bustos, and we're actually trying to put together a urine test for kidney cancer. So, because urine, again, it's a very simple test to get from patients. Everybody has to pee, right? And as far as protecting yourself with urinary tract infections, I see a lot of women patients that suffer from this. I suffered from this myself. I understand what that feels like. I think there's a lot of good products out on the market, and there's a lot of expensive products on the markets for UTI. But you can go back to the basic cranberry pills. You can buy them at Costco, and you can take them 3 times a day. And in most women, that will help prevent it. The mistake the patients make with cranberry is they don't take it often enough throughout the day. The women will be like, oh, I'm taking it in the morning. Why am I still getting a UTI? But those are the kind of things that are very helpful. You just have to take it more often.
And are cranberry pills as effective as drinking cranberry juice? Or you just don't have the concentration?
Oh my gosh, you'd have to drink like 3 gallons of cranberry juice. It would be awful. And it has all the sugar in it. And actually, the acidity of the cranberry juice is irritating to your bladder. So that's why the pills are actually a better method.
So I'm listening to the two of you talking about robotics and AI. Are older physicians at a disadvantage because they fear the technology? So if you think about it, the whole world is being impacted by AI, by robotics. You are both luckily, young enough and open enough to learning these things. But what advice and guidance do you give to physicians who are going, this is unfair because it makes other people so much more competitive? I don't understand how to utilize some of these new techniques and platforms.
Yeah, that's really an important question. I mean, it's amusing in a way that that some young surgeons that grew up playing video games seem to pick up on robotics quicker than some of the more senior surgeons. They just are adept to moving their hands around and just similar to video games. But I think that we are at the point now with the amount of data and evidence that is out there that patients will seek out surgeons that have special expertise in minimally invasive procedures. I think it's important at the same time to recognize that to do a minimally invasive operation but not have the same outcome as a bigger incision is not the way to go. The goal of minimally invasive surgery has to be to be able to do it safely, but still have this, the same, if not better outcomes than done open. And I think that they're and most physicians are pretty honest, and surgeons are honest that if they don't feel comfortable doing a procedure robotically, that they'll then refer that patient to someone like Jen who does it every week.
But I think you have to look at the fact that with older surgeons, there is a level of experience. The anatomy isn't changing. How you need to do the surgery isn't changing. So older surgeons can adapt to using minimally invasive surgery. They still understand the anatomy and the surgery and the experience and the wisdom with that and the mistakes that you can make and the pitfalls better than sometimes the younger surgeons. They just need to learn the technology, which actually comes relatively fast. So, when like I said, 10 years ago when I came, we had the robot. Anton was already using the robot. But when we started practicing together and doing cases together, it took both of us to a whole new level because I learned things about the bowel and the gastrointestinal system and operating on it from minimally invasive standpoint I did not know before. And we could be in the same space or move the robot into a different space. Maybe I had to operate on a kidney and Anton had to operate on the stomach, but we could still use the robot with the same small incisions in the same space to do that surgery. But again, I learned so much from him because we were operating and working together. So I think there's definitely growth for older surgeons because, again, what you need to do isn't changing. It's just how you do it. So.
Which brings us to adapting. We know we're living in this very fast-paced, changing world. And yes, we know AI, robotics impacts all kinds of other industries, but how it's impacting medicine, I think, is so fascinating. Will there be a time where you're getting individuals who are just trained in robotic surgery and maybe don't even need some of the other things? I mean, what do you both see as the future for this kind of surgery?
I mean, I think that every patient that is about to have an operation wants to feel safe. And if there is a way that surgeons can be even safer by, through technology. So if you're working on the robot and artificial intelligence is built in to help prevent errors or reduce errors, I think that's a game changer. And um, you know, I'd be very interested in Jen's perspective because this is an area that she's very, very involved with, and that is kind of the future, the next phase of robotics.
I mean, you have to look at this from three ways, and you have to look at one, the technology can help prepare you for better surgery. Two, experience prepares you for better surgery, right? And a person like Anton, who knows open surgery very well and robotics, is probably the best that's going to be out there. So you're right, it's different when these new trainees are coming out only learning robotics and much less open surgery. But what Anton is saying is that the technology will help, so maybe we don't need open surgery as much. But I don't think we're there yet, Nadia. I think that technology still has to grow, and it's getting better. But part of the reason that technology grows so slowly is you can't practice on humans. That is not okay. It is a lot of investigational work for these robotics companies before they can really put their product out there on the market and train surgeons. So, for example, for me, there's a new robot that's come out. And instead of many arms, there's one single arm that goes inside the patient. But even that robot for me is a whole new learning curve, right? So I have to go and take courses and practice not on humans before you put that out there.
So what do you practice on?
So normally what we do it in two ways. Sometimes we do what we call cadaver labs, or one way. But the best way, the newest way that we're practicing is we're actually able to print 3D models of tissue. So you can print a kidney with someone's tumor, with all the functioning blood vessels, put it into a lab, and use the robot to operate on it. And that's how you end up practicing, right? And that's the great technology to have.
Extraordinary. There's also huge cost, which means that the disparity in hospitals or facilities that can afford this type of robotic surgery versus those that can't. Do you see it eventually becoming more egalitarian and more affordable?
It's already happening. So there are now, the robot company that everyone was using for the long time was Intuitive Surgical. But what happened, I think, is the patents came due, and now there's more than 50 robotics companies making robots. And so, in general, they're all very similar. But you know that when competition like this happens, things tend to get less expensive because now there's more things available on the market. So you might have a hospital that uses Intuitive, and you might have a hospital that's using a Medtronic robot. And so there's hospitals out there that maybe they can't afford the Intuitive system, but they can't afford the Medtronic. And the robots are very similar. And again, the robot isn't autonomous, so it's still dependent solely on the surgeon's skill level.
So that gets me to a really provocative question, and that is, not everyone has a Jen Linehan who can, robotically remove part of a kidney, and so let's assume we have an experienced urologic cancer surgeon in rural Idaho, and they purchase a robot. How far off are we from Jen Linehan sitting in Los Angeles being able to operate on that patient in Idaho with the experienced urologic surgeon who's not trained in robotics standing by?
So that technology is there. What has inhibited this from happening has been the actual connection between the robot where you're at the console operating the robot and the other hospital. So I think as the connections get faster between, through the internet, essentially, we'll be able to do that more. There's a bit of a lag time. But in emergency situations, there have been many cases that have been performed like that, especially, this started very much so in the military, where surgeons were operating in the United States on a patient that was in Germany. So the technology is getting there, and every year it gets better and better. So that will happen very soon, that I'll be operating on somebody in a rural hospital somewhere else, but you'll still need someone there to know how to set up the robot and work the robot and put the ports in. So.
Wow and wow. I spend a lot of time talking to people about, are you a proactive influencer or a reactive responder? And Jen and Anton, I talk about that in professional development. But what's so extraordinary about both of you today is you are proactive influencers, because you are understanding the new technology and how to use it for the benefit of the patient. So much to unpack. It's been an absolutely fascinating conversation. I know Anton has an Instagram. If you want advice on cancer prevention, various things, it's Dr. Anton Bilchik on Instagram. Jen, you're on many platforms. X, you are. Share how we can follow you and gain more insight, and follow up on this conversation in a few months when there's even more progress.
Yeah, so I'm on X and on Facebook. It's Dr. Jen Linehan. Happy to take any questions. You can also find me or both of us at the St. John's Cancer Institute in Santa Monica, California. Look up our website and you'll find both of us there.
Thank you so much. This has been an extraordinary conversation on how AI, how robotics is impacting medicine and surgery. And any last thoughts as we wrap up? We have taken a lot of Jen's remarkable, expensive time.
Yeah, I'm enormously privileged to be able to work with and collaborate with, outstanding surgeons like Jen. I could never do what I do without knowing that I've got the backup of someone like Jen. And so one of the questions you asked before relates to when do we operate together? And, unfortunately, in complex cancers, they involve more than one organ. So we operate together many times. And I think we both have a very low threshold for calling each other to the operating room when we recognize that whatever we're doing involves a urologic organ or a gastrointestinal organ. And that's I think, imperative when you perform complex cancer operations.
Yeah, I think we went to a conference recently and we told the patients, we were talking to patients and we said, we call other doctors into the operating room sometimes, and they were flabbergasted at this. But this is actually the best thing you could do. I mean, why wouldn't you call in an expert every time if there was something that you were questioning? And so we work very closely together. And like I said, it's an honor to work with Anton because he's taught me so much in the last 10 years. He's an incredible surgeon. And when we have complex cancer cases, there often need both of us there to work through it for the patients and make sure we're getting all the cancer out.
Well, this is collaboration at its finest. So my brother, Dr. Anton Bilchik, and colleague, friend, and remarkable both urologist, urologic oncologist, and urologic surgeon. Am I saying that correctly, Jen?
Yes.
All correct. Dr. Jen Linehan, thank you so much for a fabulous conversation. Please look out for our podcast, Live Long, Live Strong with Healthy. I'm Nadia Bilchik, nadiaspeaks.com, and Anton Bilchik and Jen Linehan. Thank you so much for a wonderful conversation.